Professor in MMJ Institute of Oncology in Hyderabad, and she's a key person in many changes that have happened in the state of Telangana. We'll be hearing from her about palliative care for non-cancer patients and non-cancer conditions. Welcome, Dr. Gayatri, to this session.
Thank you. Shall I start?
Yes, ma'am. Yes.
Okay, just a minute. So, very good afternoon to all of you. I think I'm not very sure that I met you before, and I don't think I know most of you. But anyway, it's a pleasure coming and joining on this forum. So today's my topic is about discussing bringing palliative care to non-cancer conditions. So I thought it's a very broad overview which we are going to get today with this discussion. So my objective today would be to understand why do we need to even to talk about now. Are we ready to talk about palliative care for non-cancer conditions? Why do patients need that? And yes, if they need that, if we are convinced, that how do we identify such patients? Who are the patients who may be benefited by such kind of care? So that's the two main objectives which we thought we'll work on today, and then we'll take the case discussion. Next slide. So I thought I'll just start with our case study, which we saw recently. It's about a patient, 81-year-old retired teacher, who lives with his wife, Susan. He was diagnosed with dementia 5 years ago, now rapidly deteriorating. He's dependent for all aspects of care. He's having incontinent of urine, feces, and has difficulty in communicating. He's able to walk only 2 or 3 steps, that too with support. So this is a patient of dementia, diagnosed 5 years ago. Next slide. He was seen by general physician, neurologist, cardiologist for various reasons, because obviously he's in his 80s and he has several comorbidities. So for various reasons, he had to be seen by cardiologist. Of course, as a dementia, he's consulting neurologist, and for small little complications, he's also being seen by general physician. And 3 admissions in last 12 months. The most common admission reason was for pneumonia. The last admission lasted 4 weeks because he had severe pneumonia. He had to be hospitalized. He needed antibiotics. So he was for one full 4 weeks in the hospital. After each episode, he did not recover to the point he was before it, and he was declining in his health condition. Next slide. And in the last admission which he had, he was so breathless, he was put on ventilator and he died on ventilator. So how do people die? This one case study which I thought I'll share just to make a point, and this is nothing to do with cancer, and we're talking about dementia. So how do people die the world over? If you look at the global figure, 66% people are dying because of non-communicable conditions. If you see, it's only 25% communicable and 9% injuries, 66% non-communicable conditions. Next slide. If you look at various disease conditions where they may require palliative care among the whole spectrum of how people are dying, if you look at the disease condition, the most common is cardiovascular. Unlike what we think, the most common is cardiovascular condition, followed by cancer. Cancer is much smaller in percentage who may require palliative care, and it's a very global picture. And cardiovascular is most common. And then you have other reasons like chronic obstructive pulmonary disease, HIV, diabetes, kidney diseases, cirrhosis of liver, dementia, even some infective conditions like multi-drug resistant tuberculosis and other conditions. So if you look at the spectrum of diseases who may require palliative care, major chunk is cardiovascular disease. Next slide. So in India, so this was a very global picture. What is happening in India? If you look at India, India is witnessing an epidemiological transition. It's a growing burden of non-communicable diseases and chronic diseases, which has become the leading cause of death in rural India. Surprisingly, we think in rural India people are dying of infectious diseases, but actually people are dying of non-communicable conditions. Like I was just looking at Indian Council of Medical Research data, which they brought out in 2017, which is a very recent data, where they came out with statewide burden of different spectrum of diseases. And overall, what they found is big, huge range they given, because some states like Kerala and Tamil Nadu, they have a huge non-communicable conditions, and their non-communicable, how people are diseased. In places like Gujarat, Bihar and UP, it's more about less non-communicable. But if you see, it's a big range, how 48 to 75% non-communicable diseases. And they've given another major chunk is about injuries. And communicable is becoming much less and less, even though people are still dying of communicable. So injuries and non-communicable constitute a huge chunk who are either disabled or diseased completely because of the disease. Next slide. With the huge advancement in our health technology, people are living longer, because all these chronic diseases, if you see, it remains controlled for a long period of time until slowly they develop complications, and the dying is also prolonged. Next slide. Next slide. So this is a study which I've taken where they spoke about how it is happening in the West. They say there's an epidemic of old and fragile patients with chronic cardiorespiratory diseases. Suddenly, they're considering this as epidemic, how huge people are living longer. So they're more older section and fragile people with chronic respiratory diseases. Next slide. Sorry, I didn't realize you're controlling from there. I put a lot of animation. So congestive heart failure is commonest cause emergency hospitalization the world over, actually. And chronic obstructive pulmonary disease is 1 in 20 deaths are happening because of use and in hospitals, if you look at it. So this is how the people are dying in most hospitals. Next slide.
Ma'am, 1 second. I think there's some problem with your internet connectivity. We are hearing broken. Hello, can you hear me, ma'am?
I can hear you. So do you think mine is not very clear?
Yours is not clear, ma'am. Can you disable your video and there?
Yeah, let me try. Is it any better?
Ma'am, can you speak now?
Is it better?
Yes, ma'am, it is.
Okay, thank you. Let me know if I'm not clear any point of time. We can stop in between. So
Yes,
the
ma'am. I
point I
will.
want to make, yeah, the point I want to make here is that how here we are seeing a huge population of old and fragile people with chronic cardiorespiratory diseases, which we're going to see in our near future in most of our hospitals. Next slide. And all these diseases are not curable. If you mind you, like all this, when you're talking about cardiorespiratory diseases, none of them are curable, especially in the stages where they're reaching the hospitals. Now, this is one study came long time back, but I think it is still relevant. This is how they looked at, what they did, they looked at the symptom load of different end-stage diseases. They included even HIV and AIDS, the symptom load of different end-stage diseases, and they extrapolated all the symptoms, put together all the symptoms, and they looked at how high the symptom load is. If I'm sure you'll not be surprised to see that most end-stage diseases, they have high symptom load. And as expected, pain is at the top. 67% constitute pain. And then you have other symptoms like trouble breathing, nausea, vomiting, sleeplessness, confusion, huge number, and various other symptoms. So it's a high symptom load which you see in all end-stage diseases. Next slide. If you look at, they also try to compare different diseases, cancer against heart failure, COPD, and chronic kidney diseases. Again, if you see, if you look at, very interesting, all this very comparable symptoms, and some symptoms are much more profound. If you see COPD, dyspnea is much more profound as expected. Pain, of course, more common in cancer. Fatigue is equally common in all the conditions. But if you see dyspnea, pain, fatigue, depression, quite high prevalence in all of these conditions. And when you talk about pain, often when I speak to my colleague, they say, oh, you are dealing with cancer, you see cancer, pain in cancer. It's not so common in our condition, which is not true. Actually, if you start looking for it, you will discover that pain is so common in other disease conditions also. Next slide. This is specific to dementia, advancing dementia. I spoke about Mr. George and how the symptoms of dementia, like if you look at, they also have high degree of symptom load. Confusion is the highest. Obviously, we'll expect a lot of confusion in patients with dementia, and they'll have urinary incontinence, surprisingly pain, so common. And one of the reasons often they say acute exacerbation of dementia symptoms, they become more confused, is because of underlying pain. And very difficult to diagnose, because pain is something we cannot make out in patients with disability, this kind of intellectual disability. And but often pain is the reason that there's acute exacerbation of symptoms. Pain and constipation, these are two common reasons which we have seen in dementia. When they become more agitated, often it is pain or constipation, that you have to remember. Next slide. And as they say, the overall sufficient evidence states that the risk of undiagnosed and undertreated pain in people suffering from dementia is unacceptably high. Often we underdiagnose and undertreat people with pain in dementia. And often, because they are often old, they have multiple reasons why the pain conditions which use in geriatric conditions. Often there's a fall, there's an injury, it's a very musculoskeletal kind of pain, or they have some underlying other comorbidities. Next slide. Now, if you look at this, I'll walk you through some important disease conditions and look at the kind of problems which each disease conditions you face. Let's take heart failure. Now, heart failure in the UK is quite high. They say it's a very UK figure because we don't have figures, unfortunately. It's all I'm quoting from some international figures. If you see, heart failure is so common in UK, and they say the survival rate is worse than breast or prostate cancer. People there, they don't die of breast or prostate cancer. They die of heart failure. Next slide. In heart failure, the most troublesome symptom which they found is dyspnea and pain. Obviously, we know that, but it's again with study, they kind of pinned it down that dyspnea and pain is so common. And pain and shortness of breath inadequately addressed in end-stage heart failure, even in patients admitted to hospital. Because that's not a priority. All the time we are chasing, trying to reduce the impact of heart failure, the decompensation. So we try to control, manage heart failure. We don't really look at pain and shortness of breath. Next slide. Look at COPD. I spoke about heart failure. I'm just putting it very simply because there are a lot of very technical details we can go into in each disease condition. But COPD, if you look at it, patients with COPD scored significantly worse than those with inoperable lung cancer on activities of daily living, physical, emotional, and social functioning. What they did, they compared COPD and inoperable lung cancer, and they compared what is happening in their lives, and they found that they are much worse in COPD when you talk about the physical, emotional, social functioning. And they were more troubled by shortness of breath. COPD, if you compare with lung cancer, 94% versus 78%. They were more troubled by shortness of breath than lung cancer. Because again, we think, oh, it's cancer. That's why it's so much of suffering. But we don't realize is even COPD, there's so much of suffering. Next slide. And even though so much of suffering, none of them received any specialist palliative care services. Now, this is a UK figure again. I can imagine it's not much different in India. In UK, even though so much of symptom, they never received palliative care. Next slide. When given the choice, when both the groups, lung cancer and COPDs, when they gave the choice, if we have the choice, what kind of care would you prefer? They said, I'm talking about advanced COPD, most preferred comfort-based care, and they did not want ventilation. They never wanted ventilation. 80% they said, please don't put me back again on ventilation. But what happened? Next slide. Next, yeah. More COPD patients received ventilation because there hardly any preparation, hardly any communication about what kind of care they can receive. And they were put on, that's in a very natural course. Patients who are breathless, they were put on ventilation. 70% received ventilatory support versus 20% in advanced lung cancer, even though symptom burden is quite high. Look at the kidney disease. So we spoke about COPD, we spoke about heart disease, kidney disease. Again, there are studies which quotes that have an extremely poor quality of life. They need frequent hospitalization and a very poor prognosis comparable to that common malignancies. Kidney disease prognosis comparable to common malignancies. Next slide. And dyspnea, confusion, pain, anxiety, and depression are very common during last few days of life. Again, they did the exclusive study on end-stage kidney disease, looked at the symptom separately, and they found that it's so high. Next slide. If you look at, so most common, I recently attended a workshop on all the leading nephrologists and palliative care people came together in one forum, and we discussed about end-stage kidney disease. For them, it was all about dialysis. They said, even there is no option for transplant, what we offer is do dialysis, and dialysis fixes the problem. They say that when you give dialysis, all the symptoms settle down. But what they agree, when I ask, do they die? Yes, of course they die. Where do they die? They say they die on dialysis, they die after dialysis, or they die before. They are dying, but they still feel dialysis is one weapon they have to fix all the problems. And so what happens to dialysis? So it's a very international picture. Withdrawal from dialysis is the most common cause of death worldwide, reflecting the very poor health-related quality of life. I can imagine in our own population, patients, they simply stop going at one point of time. They just give up on dialysis and they die. This is what happens in most kidney diseases. And the high level of disability and symptom burden in advanced CKD is not necessarily improved by dialysis. Contrary to what we believe, all end-stage kidney patients you put on dialysis, the symptoms will be sorted. No, it is not true. They still suffer from symptoms and disability. And this is a taken consensus, this is a very nice consensus document about supportive care and CKD, which came up in 2015. And often this is quoted. This was a very international consensus body which sat together. Next slide. If again, given the choice, if they recognize it's a terminal nature of the disease, many patients prefer comfort care and they do not wish active resuscitation. Still, there is a relative lack of preparation for death. Nobody prepares them for that. If given the choice, they do wish for that, but nobody talks about it. Nobody, in all of these conditions, end-stage dementia, heart disease, kidney disease, COPDs, nobody talks about the progressive nature of the disease and how these diseases are actually, we are talking about being terminal, getting terminal. We brush aside that issue in most of these conditions. Next slide. So why is that happening? Why is there so much of barrier to having a better and quality end of life care, better quality of life focus care in all of these patients? What are the barriers? What do you think is the barrier? So I'm curious, a couple of points if we can think about. We can just hold here, pause here. Why do you think that so much of the most historically, our whole of discussion is around cancer, palliative care? When you talk about suffering, it's cancer. When you talk about pain, it is cancer. When you talk about palliative care, it's all about cancer. Why is that historically other end-stage problems are not addressed or discussed about? Why do you think? Can I take any thoughts or comments?
Anyone like to comment on it?
If you can't speak up, you can type it in the chat session.
I can imagine all of you must be thinking, and first time maybe you are even thinking about it. When most of us, even when I was working on this presentation, like even I was thinking, like when so much of burden, why is that we don't even talk about it? Maybe I will come up with some reasons, and if you have any more, you can always add. So, one important thing which comes up in most of this discussion is prognostic uncertainty. Even in that nephrology group, with all the leading nephrologists in the country, they sat together. Okay, I see some comments here. It's nice. You can please write down your comment. I think, ma'am, cancer has such an awareness of drastic condition among public population than others, which is very true. When we talk about suffering and pain, it's all about cancer for some reason. We fail to recognize in other conditions, and that's massive. Where we maybe so much is spoken about cancer and fear. Cancer means immediately the fear is pain and suffering. Of course, along with death. Death happens in all conditions. Very true. Thank you, Dr. Krishna Kumar. So, one is the prognostic uncertainty. A very interesting study. When I said this nephrology group I spoke with, they said, how we know? It's very difficult to estimate when to stop, when to give up all this effort. So the one study I thought I'll share with you. Here, the patients with heart failure were predicted to have greater than 50% chance of survival for more than 6 months. Study. They predicted that patient will live for another 6 months, but many died within 3 days. It was so prognostication is so difficult in all these conditions. Cancer, I think it is a little more predictable. That's what they say, that you can still say, okay, cancer means when I see, maybe it comes with experience that we know that when a patient is dying, we know he is dying. But all other conditions, we are never sure when he's going to die. So that's one important reason is prognostic uncertainty. Next slide. So I'll discuss the disease trajectory of different 3 conditions, just to make the point that why it is so difficult to prognosticate, like when the patient is going to die. If you look at the cancer disease trajectory, I'm sure you have seen, all of you seen this slide. So on the y-axis is the function ability, patient's functional ability, and on the x-axis, the life of the patient. If you see, initially when the patients are diagnosed with cancer, they have high functional ability. And it goes on for a period until they receive cancer treatment, they may undergo remission, so they are doing well. And when the disease comes back, there's a rapid decline. When disease recurs, relapse, rapid decline, and very quickly it leads to death. This is a typical cancer trajectory in most of the cancers. This is what they see in cancer. Let's see the other disease trajectory. Next slide. If you look at heart, lung, liver, or kidney diseases, these are all end-stage other diseases. Often, yes, it starts with relatively high function ability. But if you see the disease trajectory, often there will be some complications. For example, when it is a kidney disease, or lung disease, acute infection, they go to the hospital, they get treated, they become all right, they come back. Then they live for some more time. Again, there is a dip, there's some complication. They go to the hospital, get better, come back. Again, for some period of time, they're in the home. Again, there's a dip, they develop some complication, infection or some kind of complication, they get better and come back. But if you see, over a period of time, there's a gradual decline of their functional ability. Yeah, and we don't know which dip, if you see these dips, which dip he is going to die. It's very difficult to predict. One of these dips, they may die. But when do you think you should start thinking about progressive nature of the disease, or he's declining, or he's ending towards end of life care? Which state will you start thinking about this? Because it's very important to know that, so that because then only we can start this conversation with the patient and the family. Okay, listen, I think we are Now here we are reaching a stage where we're talking about a very advanced disease and you're reaching end of life care. At what stage will you decide? You want to take a guess?
Anyone wish to answer?
I don't think there is actually, I can see that uncertainty, and I don't, even I am like, it's very difficult. Well, let's accept that it's very difficult. But I think when there's a frequent hospitalization or frequent onset of complication and the frequent decline in physical conditions, and the physical condition become so decline and become less that you think he's not doing well. I think some of that dips we should start this conversation. Maybe the third dip I would start this conversation that he's nearing towards end of life, somewhere around that point of time. Thank you for showing that. Maybe when there's a steady decline in general condition, I think we should start this conversation. It should not come as a surprise because we know that he's not doing well. So this is a kind of stand. We should be aware of this stand that yes, we have to start this conversation and prepare the patient and the family about the eventuality. We can always tell them, yes, this time is come around, but this is high probability. Again, we'll have a complication. We are not sure whether every time it will be like that. That conversation is very important. Next slide. So we spoke about cancer and we spoke about all other end-stage diseases. Now this is about typical what we see in old age, geriatric family, geriatric population. In geriatric, already they are very frail. So there's a gradual, with or without disease, there's a gradual decline. There's a frailty, gradual, and especially dementia also then becomes very rapid decline, but they're already frail. So, and it goes on and on, and before they just die. I think here in the first diagnosis itself, we must have this conversation that it's a very progressive disease. It is not that we can arrest this disease. Its patient is going to die. So eventually, it's a progressive disease. That indication is very important. That we tell them from the beginning and tell them that this is what is going to happen. Next slide. I put it all together. If you see, very interesting. They did one study again in United Kingdom in 2010. If you look at organ failure, cancer, and frailty, 3 different conditions. But how are people dying? If you look at it, 2%, it's acute. Let's not talk about that, sudden death. But biggest chunk is frailty, that gray area, and then comes organ failure, then only it's cancer. So 6 and 7 and then 5. So actually we have to have this conversation. So it's not just only for cancer we'll deserve this conversation. This conversation should happen, or this preparation towards for the end of life care or providing palliative care should have. It should be there because this, if you look at the figure, they are dying, they are also dying and they die. Next slide. The first barrier I spoke about is prognostic uncertainty. So they said, not knowing how long the patient will live creates uncertainty, and it paralyzes the doctor. They get paralyzed as to I don't know what to do, and that prevents them from seeking palliative care. So this is one most important reason, barrier often quoted is in other non-cancer conditions. Next slide. Another reason barrier is the natural desire to be optimistic and to avoid alarming patients about unnecessary thoughts of impending death. I remember we have a very leading neurologist in our city, because of which our palliative care and dementia program, I think, relatively is going quite well in Hyderabad city. And she is very pro-palliative care. But when one of the discussions, when we had this dialogue, and I said, I think every dementia patient, at the beginning itself, we should tell them that they got dementia. She got very anxious about it. She said, no, how can we tell them that? They'll give up hope, they'll be anxious, they'll be doomed. We should not be telling them like that. So obviously, they have this they feel that they're alarming, they get alarmed and they feel that patients will be alarmed with thought of unnecessary burdening them with information and impeding that. We should not be doing that. That's another barrier which becomes in the way of providing palliative care. Next slide. So often when you talk about incurability and progressive disease, it's not like cancer. I don't have cancer. So they think only cancer is progressive and incurable. So they don't want to accept that. Next slide. And medical perception, we all know that we feel death is a failure. If we fail, a patient dying of COPD, then I failed because I could not fix the problem. We feel it's a failure. And we don't know how to manage symptoms. That becomes another barrier to providing good palliative care. And we don't have enough specialists in palliative care. The fact that we barely have few people in and around our community providing palliative care. How many specialists how many people do you have providing palliative care? So imagine if you take up all these disease conditions, who is going to take care of them? So the lack of specialist palliative care resource itself is a big. Next slide. And of course, the lack of evidence. I must talk a little bit about evidence. All evidence about pain, how to manage pain, about use of opioids in pain management, how to manage neuropathic pain, how to manage dyspnea. If you look at the studies, it's all cancer-based studies. We have very limited study on all of the symptom management or communication issues, end-of-life care, prognostication for other diseases. So we really seriously, we lack evidence about all these conditions. That's a big barrier. Next slide. Next. Yes, like we discussed, like dementia, failure to recognize as a terminal illness and poor preparation. There's no preparation. We fail to recognize as a terminal illness. And their caregivers are unprepared. And often that leads to aggressive life-sustaining measures instead of comfort care because they're hardly prepared. So there's any crisis, the natural option is go to the hospital. Once you go to the hospital, you're shifted to ICU. Once you're shifted to ICU, you put on ventilator and then that's it, and you die there. That's a very normal sequence of all end-stage conditions. Cancer, I think they feel much better because at least cancer, they get to reach palliative care somewhere. Next slide. Hospital policy, maybe that's a big challenge in most of the hospitals. They don't recognize palliative care as a need, and of course palliative care services not being available because you cannot say that I have now this patient with chronic kidney disease, I will not give dialysis. If you don't give dialysis, then what? You cannot tell them go home. You have to have this provision. Okay, I'm not giving dialysis, but I'm going to give palliative care so that you don't suffer. That option should be there. Next slide. So when to refer to palliative care? Advanced stage. So cancer is much more predictable. We know that when to refer. Still, there's a lot of prognostication. They have a lot of criteria when to refer to palliative care. Of course, they all recommend very early on referral, early stage referral. But still, when do they clearly they know they need palliative care? There's a lot of discussion around that. I just thought I'll share one example. One good example, I think all of you should take that print out and keep it somewhere and share with your friends and tell them, hey, if you have these conditions, I think they may be supported better by palliative care. So I'll give you one example. Next slide. Now this is one website if you go to, it's called SPICT, Supportive and Palliative Care Indicator Tool. In this there's a website, whole lot of information around this indicator tool, when to refer for palliative care. Very interesting website, and this is a very interesting document, and they look for 2 or more general indicators of deteriorating health, the criteria, and if they're positives, and if they have cancer, this is this. If they have heart disease, these are the conditions. If they have kidney disease, these are the conditions. Like that, they have given clear indication for different conditions when to refer to palliative care. So I'll just give an example. I'll go into detail because it's not very easy to read on this. I'll give an example. Next slide. So they said when to refer, when you have heart or vascular disease, when to refer. They say New York Heart Association class 3 and 4 with symptoms like breathlessness, chest pain, fatigue on rest, and severe inoperable peripheral vascular disease, gangrene, pregangrene, extremities. These are indications where you must refer to palliative care. Next slide. Next. Liver disease, when to refer. Advanced cirrhosis with 1 or more complications in the past 1 year. If you have 1 or more of these complications, along with advanced cirrhosis, please refer to palliative care. like hepatic encephalopathy, hepatorenal syndrome, bacterial peritonitis, or diuretic resistant ascites. One or more of these symptoms, think about palliative care. Next slide. Kidney disease. When do we refer to palliative care? Stage 4 of chronic kidney disease and kidney failure complicating other life-limiting conditions or treatment. Suppose kidney failure with cancer, kidney failure with diabetes, and patient opt for stopping dialysis. Patient family and the physician say no more dialysis, and advanced diabetes with failing condition. These are the indications when you refer to palliative care. So these are taken from SPICT. It's not my observation. This is that they have given an indication. It's very internationally with the consensus. Okay. They also talk about what to do. Suppose now you get a patient identified with having suppose CKD, chronic kidney disease, and they refer to you. And what is that you can do in the community? Because all of you may not be working in specialist hospital. You're working in the community and you see such patients. How is it you first see if you can still optimize the treatment, the actual disease condition. Suppose you have a patient with chronic kidney disease. Do you want to use diuretics? Diuretics is like steroid in kidney disease, they say. We use a lot of corticosteroids in cancer patients like that. They say diuretics is like a corticosteroid in kidney patients. So they say still see if you can optimize the treatment if possible. Very important, explain to the family and the patient the extent of the disease and irreversible nature. Very often you are the people who are going to do that. You may have this, you will be put to this task, you will be required to do this task. Of course, you are the best people to manage their symptoms, psychosocial, spiritual, and physical symptoms. You are the best people to do that. If you recognize these patients, definitely you can help them. And manage training the family, empowering the family, you can help them. Advanced directive. Can you hear me? Can you hear me, Vijay?
Yes, ma'am, we can.
Yeah. So advanced directive means asking them, suppose in future, once again this complication arrives, what is the kind of care would you like? Would you like to go back to hospital again, or you want to stay back in home? If you opt to stay in the home, what is that we are going to do? What is the kind of care we can offer you? So that kind of discussion, what we call the advanced directive, is very important, which you can help if you recognize this kind of conditions. Next slide. And of course, giving that kind of ongoing support in the community, how to access medication, where do you get opioids, where can you approach us, where is our center, can you reach us on the telephone? So this kind of help you can offer them, and it's very, 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 it's so significant because they'll be so grateful to you for giving this help. These are different ways we can do that. Managing symptoms, telling them, having this conversation about the terminal stage of the disease, training the family, advanced directive, and giving the ongoing support. These are the different ways you can help these families. Next slide. So to sum it all together, sum it up, the recommendations people talk about when you're managing non-cancer palliative care condition. One important recommendation they give, number one, next slide. Access to palliative care should be based on need rather than diagnosis, irrespective of where they stand in the stage of the disease. If there's a need for palliative care in terms of symptoms, psychosocial support, and planning, it should be based on that, not on the diagnosis of he's got chronic heart disease stage 2, and then he has to be, yes, he may require the curative or that kind of treatment, but it's also, he should have the option to also have access to palliative care. Next slide. The second recommendation, they say, a strong recommendation offering palliative care to anyone who, in all probability, is likely to die within next 12 months. They strongly recommend that if you suspect that this patient is not going to live for another 12 months, you must recommend palliative care. And often, I don't know how many of you are aware of the surprise question. This we use a lot in cancer prognostication also. We say the surprise question. Would I be surprised if this patient died in next 12 months? Ask yourself this question. If you are not going to be surprised, I think he needs that preparation. We use for cancer at every stage of cancer, whether it is early stage of cancer, when there's a relapse, when there's a recurrence, progressive cancer, end of life care. So in end of life care, when they asked how long, we say, then ask yourself this question: would I be surprised if this patient died in next one month? No. Then you have to tell them that this is what I'm expecting. So this surprise question is very helpful. But in general, a strong recommendation to offer palliative care to anyone who in all probability will die in next 12 months. The another recommendation is that even if there is insufficient capacity for specialist palliative care service to support patients with non-malignant conditions, care could be improved by education and training. They say that, yes, we don't have enough palliative care people, but healthcare professionals such as cardiology or respiratory specialists should be trained in areas of symptom control relevant to their practice. All broad super specialty dealing with such problems, they should have basic training in palliative care and symptom control. At least it can begin there. At least they'll have that approach. They should recognize when to stop, when to help the patient and the family take a more palliative approach, how to manage symptoms, these kind of, and communication skill training, all of them they should receive. So that's the only way we can right now improve the scope of palliative care in all this disease spectrum, because we may never have in near future enough palliative care specialists. So that's another recommendation they give. Next slide. And the last recommendation they give, so first recommendation, palliative care should be need-based. It should be strongly recommended if you suspect they may not live for another next 1 year. And third, training. And the last one, the research. They say we need to do a lot of research. And in India, it has to be really India-specific research. We need to understand what is the need. We have to do a need assessment about the need for such conditions in our own country, and evidence, looking at more evidence about the use of certain medications and things like that in non-cancer conditions. We need, because it's only the evidence which will help us to prove our stand in the community, health medical community. Otherwise, they will never accept us. So we need to do a lot of research. I stop here. I take questions if there are, and before we go on to the next session.
Thank you, Dr. Gayatri. We expect your comments or questions, and those who can't speak due to the network issues, you can always type in the chat session. They are all usually silent, active listeners. Never speak back unless you actually point them and talk to them.
I can totally understand that, because generally in Zoom, we don't really connect with people like that, and we don't know each other much. That's, I think, one big challenge. And also, I think they're scared, maybe. But you can chat, actually. You can quietly put down your thoughts on the chat, and we'll take the discussion if you're very scared to speak. But it'd be nice to hear from your view on, because I was told that all of you work in a hospital where it's a very multi-specialty hospital, and you get to see a lot of these kind of patients. So it's very good to hear from you, your experience of what's happening to your patients there.
Yeah, exactly. If you don't have any queries, at least you can share your experience in your setting, because we work in a different setting and you people work in a setting where you see most of our non-cancer patients maybe.
So we have Dr. Anjana Surat, Hyderabad, I think. A very senior palliative care physician.
I will just share my experience about non-cancer diseases for palliative care. At one time, I had done an awareness program for multiple corporate hospitals to suggest that even non-cancer diseases can be covered by palliative care. But before I would start my chat, they would say, but we don't have cancer patients in our hospital, so why are you talking about palliative care here? And at the end of it, I think most of them did get convinced that yes, you can use it for other organ conditions also. So, but despite that, I don't think it has made any dent on anyone. Nobody has started special palliative care services in their hospitals, nor have they got any specific doctors to look after patients who need the care. My worst experience was with the nephrologist. When I said, how do you decide when to stop dialysis? Most of them said, no, there is no need to stop dialysis. I said, have you ever looked at the functional status of the patient? No. Have you ever looked at the social status of the patient? Answer was no again. And I mean, they did not see anything beyond the kidney, I suppose. And I don't know whether they were convinced that they should be doing something different, but I made my attempt. Thank you.
Thank you so much, ma'am. Thank you so much for sharing your experience. And we have two charts. What kind of palliative measure is given after stopping dialysis in end-stage kidney disease?
Thank you. Can I take that question?
Yeah, sure.
Yeah. So, when do we stop dialysis? There are two ways. So, when you diagnose end-stage renal disease, the conversation should happen there that it's an end-stage kidney disease, which means that it's a terminal event. And the choice, that is the recommendation. It's not my view. Recommendation is that the nephrologist should have this conversation, and the patient should have the choice whether to go for dialysis or to go for conservative treatment. They should have the choice. Now, the patient may choose dialysis or patient may choose conservative treatment. That's the situation when they choose, when you don't take the dialysis. The other condition which we see very common in our population is that they stop dialysis because they just become very fed up. The general condition deteriorates and some point of time. Nobody tells them to stop, but they just stop on their own. In either stage, when you stop dialysis, what are the symptoms which you're going to see? They're going to develop symptoms like dyspnea, which is the most common symptom experienced when you stop dialysis, because the body gets filled up with fluid and you develop dyspnea and pain. And third is delirium. They'll come back to hospital. Even though they decide to stop dialysis, they come back to hospital. And when they come back to hospital, they're naturally, when it's the nephrologist comes into the picture, and they shout at the patient that, why did you stop dialysis? I told you not to stop dialysis. Again, they'll put them back on dialysis. They don't realize that this dyspnea, pain, or delirium can be managed.
And your voice is
otherwise. Without dialysis also we can manage pain. And people actually live quite a period of time. That option is never there for them. And the nephrologists, they don't know, and that option is not available in most of the hospitals. So when you talk about what palliative measure, it's all about managing symptom and of course giving psychosocial support.
Your voice was breaking in between, so I guess you were telling that if they are not planning to go with dialysis, we can do a lot about symptom management, as in dyspnea, delirium, pain. That's what Dr. Gayatri was trying to communicate, I guess. In between, your voice was breaking. There is another question about how to go on with awareness among professionals about the basic concept of palliative care, that it has to do something beyond cancer. Dr. Gayatri may be trying to connect back.
Hello, ma'am.
Sorry, I lost in between, but yeah, this is the point. I don't know where I lost the conversation.
There is another question: how to deal with the awareness among clinicians about the basic concept of palliative care. How to work on that?
Yes, I think Dr. Adina Surat tried that, and that was a good attempt. I think we have to, massive awareness going to different hospitals, and we have to have these kind of forums. Now, the forum which we met recently, this was all Indian Nephrology Association. We got together all of those people, And they have gone back with this thing that now we are going to bring up one position statement of Indian Association of Palliative Care and the Nephrology Indian Renal Group, talking about supportive and palliative care in kidney diseases. So once we have this kind of position statement, I think, and then we can showcase this with all the nephrology people. And we also spoke about bringing curriculum into their nephrology training. So I think we have to work with different bodies like this to bring awareness and more competency into their group.
Yeah, it's about finding your space, getting 5 minutes, 10 minutes initially to talk to other specialties about what palliative care can do in their area. Making them understand that you are there to help them, not to interfere in their treatment, but you are there just to help with them to give good symptom control so that the patient may take up more, can go on with the treatment much more easily and take up their symptoms when they are approaching towards end. And there will be some time that they have to stop the treatment, right? There must be some place that they can rely upon. Start with collaboration early, it would be better. There will be better transition from the curative care to the supportive care. So that's what I believe. So I'll just conclude Dr. Gayatri's session if there is no other question from the participants. So we saw that the prevalence of non-cancer illness when they are dying. So 66% of people die in non-cancer and almost nearly 40% with cardiovascular illness globally. And in India, we have increase in non-communicable disease and chronic diseases. And many symptoms in cancer and non-cancer are quite similar. The symptom burden is quite similar. And some of the symptoms are even worse in non-cancer than in cancer. And when you're working with non-cancer palliative care, prognostication becomes very difficult. You can't predict the pathway, and there is no specific time that you can mention when to start palliative care. We saw the various trajectories in terms of cancer and non-cancer illness, and we have heard about various barriers to incorporate palliative care into specialties other than cancer. And we saw a very useful tool which you can go through, the SPIT tool, so that may be helpful maybe in advocating, when you are advocating about non-cancer palliative care. Any more questions from the participants? Or any comments if you want to share some experience? Because you might be hearing about palliative care for the last few weeks, so you might have talked to your friends or colleagues about palliative care, so you might have had some experience in dealing with that. If not, we can move on to the case presentation for today. Dr. Al-Sapna. Can you unmute yourself and start the presentation?
Hello, ma'am.
Yes, if we can hear you, you can start.
Hello, ma'am. Am I audible?
Yes.
Okay, ma'am. I am Dr. Al-Sapna, has completed MBBS in Travancore Medical College, and I am going to present a case on RTA. Ma'am, slide please. 26-year-old male with diagnosis of blunt trauma abdomen with intraperitoneal bladder rupture, pelvic bone fracture, blunt trauma chest, and neurological deficit in left lower limb. Ma'am, next slide, please. And he was presented to the ER with complaints. He was crying loud with pain, severe blood loss, and extremities were cold and cannot appreciate sensation over left lower limb. History of illness. 26-year-old male was brought to casualty with alleged history of RTA. A KSRTC bus ran over this person who was standing beside his bike on 16/12/18. The driver ran away and the tire was taken off from this body after 10 minutes. He was brought to ER and after he was shifted to priority 1 and they were advised to give blood transfusion, supportive measures and analgesics for his present condition, but the bystanders were not willing for to continue treatment in here and was asking for discharge at request. And even though they were explained about the risk of transportation, they took the patient, and in the next morning they came back with non-availability of ventilators in other hospital. And when he was brought to ER the next day morning, he was unresponsive and extremities were cold, profuse bleeding from the site of trauma, pulse was feeble with low BP, open wound over the left side of the abdomen, 20 into 15 centimeter, and the peritoneum was visible. He was intubated in emergency department. Treatment and significant investigations. Emergency laparotomy was done, which showed multiple serosal tear in the sigmoid colon, ileum, and intraperitoneal tear in the dome of bladder, 3 into 3 centimeter, peritoneal tear, crushed wound with tissue loss involving iliac fossa and left groin with crushed and comminuted fracture of left iliac fossa. Bladder repair was done, drain was kept in situ, and abdomen closed in layers. External fixation was done. After this, CT pelvis was taken, which confirmed the above findings. CT chest showed multiple rib fractures, and CT dorsolumbar spine showed slightly displaced left transverse process of L2, communicated fracture of left sacrum with diastasis of right sacroiliac joint. He was found to have hemoglobin 5 and blood transfusion was given. Metabolic acidosis was corrected. Skeleton traction with 10 kg and later 8 kg was given and skin traction was done. Now daily cleaning and dressing, physiotherapy, antibiotics, analgesics and other supportive measures are given. Coming to psychosocial aspects, well settled and financially stable, have a sister whose marriage was fixed but now it's cancelled. As her only wish was that her brother should be there, but as this situation they postponed the marriage, but the groom's party was not willing for postponing the marriage and they dropped this proposal. But now they find difficult to get money and they are ready to expend even more. Their only wish is to bring their son to normal life. He thinks that his reason for his family is worries and depressed, find difficult to depend his parents and sister even for his daily routines. Medications. Over the course of treatment, he developed multiple episodes of loose stools and fever spikes, which was managed accordingly. Pus culture showed MDR Klebsiella, which was treated with tigecycline and meropenem. He was extubated after 1 week, and he was on urinary catheterization, and it was removed after 2 weeks. Next slide. And the main concern is his dependence on his family, about his immobility, and sister's marriage was dropped. Parents pray to God nobody should experience their children suffering in front of them. They also have a guilty feeling that they got discharged at request and wasted a lot of time in saving his life by in searching of hospitals for their better care. Now next slide. And a summary. 26-year-old male brought to ER with alleged history of RTA. KSRTC bus ran over him. He was intubated due to profuse bleeding. He was intubated and due to profuse bleeding from left side of abdomen with an open wound and peritoneum was visible. Emergency laparotomy done. Abdomen muscles were approximated. Bladder repair was done. External fixation done. And now he's in a stage of recovering. Skin grafting done. Cleaning and dressing and physiotherapy continuing. Now he is able to appreciate sensations of a lower limb and slight movements are possible. And from my point of view, I have chosen this scenario because after joining this session, I came to know that palliative care is based not only on cancer patients, it is based on other patients who's to improve the quality of life. And thanks to Pallium India for such a session. Discussion points. Is the age of patient a factor that doctors have the feeling that this is aged and they think that there is no more time taken to go, but younger one have a greater value and doctors family members will go to their extreme to save the life? Is it correct? And if it is correct, is it the meaning of hospitality? Do the parents have to feel guilty that they have lost their valuable time in saving their son in going in such a hospitals? Thank you, ma'am.
Thank you, Al-Sapna, for the presentation. Dr. Gayatri, we have
Dr. Gayatri?
Yeah, very good presentation. Thank you, Sapna.
Thank
I would like to hear from views from others about very important two questions which he raised. Yeah, one question from what I understood, what she's saying is because he was young, was it all right for the family to go to all to save? How do you deal with this guilt the family is having about losing the valuable time? How do you deal with such situation? Any thoughts, comments?
Anyone wish to comment on the question?
Very much. Madam, Dr. Anjana Surya, would you like to share what?
Hello.
Yes, Dr. Anjana Surya.
The age is not a factor anywhere for consideration of palliative care. It's the state of illness and the requirement at the time. It may be in the acute setup, it may be in the chronic setup, or it may be at the end of life. So I don't think that is one thing that anybody has to hesitate to extend palliative care. The other thing is I didn't get the second question.
The question is how to deal with this guilt the parents having, that they're having that guilt that they lost valuable time trying to save the child in search of hospital.
Well, I think this scenario is for total care here, that everything has to be taken care of, all the 5 factors that we deal with, and that should see the patient and the family through their difficult time, and that's the way we can extend comfort to all of them. That's what my take is.
Any more comments before I give my views and share my views?
I just want to clarify with Alchandra, your concern was about spending too much time, money, and conscious efforts for something which is not going to be correctable only because he's a young patient. Is that right?
Hello, ma'am.
So your question, the first question is about spending too much of money and time and attention to one patient who probably may not be walking again, we don't know, and only because he's young. Is that what you?
I think because the patient is young, the doctors, family members, and all concerned about him, and they had a positive approach in managing these conditions. But if it comes in an elderly patient with an RTA, they will think there is not much to go, and we can wait and see. It will be like that. Experience a case like that. That's why I made this question.
Yeah, I just wanted to clarify that point.
So, if I look at this issue, a very unfortunate situation, I must say, I see two ways to deal with it. One is how to look at the whole issue ethically. What is ethically right in terms of what is best for the patient and the family, ethical issue. And second one is about communication. How do you communicate? So the one ethic, whenever we in dilemma, how much to go, to what extent should we be going with our effort trying to save? Often we come across this in end of life care situation. To what extent should we be going for treatment? So often when we are not very sure, we go into the cardinal principles of medical ethics. We try to put those things in the perspective. One is patient autonomy. One is how much the patient wants. Second, doing good to the patient. Means by doing all this, are you really doing anything good to the patient? But at the same time, do no harm. Are we doing by or doing, or are we producing more harm by going to all these measures to do no harm? And fourth, valuable ethical principle is giving justice, fair distribution of resources, spending all the resources on a effort which is which is may or may not be useful, but it is compromising the well-being of other members of the family or wasting the resource of the hospital or the community at large. So all this resources, fair distribution of resources. So when you're not very sure what is right or what is wrong, you may have to think about these ethical principles. Questions autonomy, which is very most important. Do good, do no harm, and fair distribution of resources. So these guidelines sometimes very helpful for us to make a decision, because often there is no right or wrong. It's a very thin line between this side or that side. So sometimes these things help us to make a decision. And about this guilt, we see this guilt often in the patients and the family. Because of me, this happened. Probably if I had more money, I could have done this for my child. If I had more money, I could have gone to another hospital and done this. So they have, and if I had other means, maybe I could have given better care. So this guilt is always there in the family and the patient. So it's all about how well you communicate with the patient, family. Just to sit down with them, understand what they're undergoing, giving empathic statements, saying that it's quite all right for you to feel guilty like that. Anybody in your position would feel guilty, and it's quite all right. But even in any other in your situation, if, any other person that felt like that, what they tried their best. That kind of communication skill, giving empathy statement, and just be with them. These are things which are often helpful to deal with the guilt the family often experience.
I think here we missed the last few sentences about dealing with that guilt. It was not clear. Just till the point that conveying that it's okay to feel guilty, and after that it was broken.
So I just want to say that it's all about communication skill to validate what they're feeling.
Yeah.
Validate that it's quite, anybody in your position would feel like that. It's quite all right to feel guilty like that. Validate and praise their effort, saying that you've done so much for your. Do you realize that you've done so much for your son? And then also making some kind of partnership statement, saying that let's see now from here onwards how is the best we can help to care for your son better. So these are the few communication skill techniques which we use to help to deal with the guilt they often experience.
Dr. Alsapna, any comments from you?
No, ma'am. Thank you.
Are the patient, are the patient and the family, like the whole family, still there in your hospital?
Yes, ma'am.
So you have a chance to try out the communication scenario, right?
Yes, ma'am.
You can go back. Can you go back and talk to them? Just at least to listen to them.
Yes, ma'am. Of course.
Any other comments? And my concern is, Dr. Alsapna, if you talk about kind of palliative care approach, would your colleagues agree with that?
Yes, ma'am. They all agree.
Okay, that's a good thing. Like,
Because when I saw one case coming to the emergency department and outside this hospital, and when I was doing general GP, going for GP, and I saw an elderly person coming to the ER, and the doctors were, oh, he's an old person and nothing to do better, and we can wait. And that was the approach of the right doctors. But when I came to see this case, they are all much concerned about this patient, and I'm happy that I'm satisfied with the treatment what that boy got from here. But still, I think all are not getting the equal treatment in the society.
anybody else would like to comment on that? She feels like there is a kind of the allocation of resources is not similar. Like some people will get more attention and more resources, and some people don't get that.
Hello.
Yeah. Yes, Krishna.
Hello, ma'am. Ma'am, actually, I too want to share the same fact that
Yeah.
most of the physicians are not much aware that the palliative care is a branch that is available for all type of diseases or all type of clinical conditions other than cancers. And many of them are thinking that palliative care or this much of supportive care is available only for these carcinomas or such type of disease only. And that is, I think, that is the main issue, that many of our colleagues or many of the specialists will not be agreeing to continue to palliative care or supportive care for their patients, because that is like they are losing their patients, and the patients and bystanders are also, they are not much convinced about this palliative care, because in case of a kidney disease, the bystanders are well aware of this dialysis and all, and they are more prompt to do these dialysis and life saving measures rather than the supportive and palliative care, because they want to save their relatives and all. They have the concepts like that. And the thing I want to ask is, from this case, we understood that palliative care can be provided in emergency situations like this and all. For this kind of a case, our society is so much adopted to save these young people than old people, I think so, because in this case, this man is a great support to his family. So the doctors, the emergency physicians, and even the healthcare providers are more cared to protect and to save such type of patients than all patients, because that is a big concern. And how can we introduce the palliative care into such an emergency condition? Because emergency is always emergency. We cannot think more, we cannot communicate more with the patients, because we want to act as soon as possible. Then how can we introduce a palliative or supportive approach in an emergency situation?
I think in our country still in the emerging state, I guess. Dr. Gayatri?
It's a very valid question, very valid thought actually. So more and more in very good hospitals, they say what we call it is palliative care and critical care interface. So they say that in any casualty or any emergency, there should be an availability of palliative care personnel. Because why do patients come to casualty emergencies? Other than if you see trauma or myocardial infarction or acute cardiovascular event, it's often because of chronic disease and acute exacerbation of symptoms. So when it is a chronic disease with acute exacerbation of symptoms like pain, delirium, dyspnea, often there's a huge role for palliative care. So a good emergency service, they should have a palliative care personnel available. That's what more and more centers are talking about. Not in India, but generally everywhere. I think that's a thought we should have in our most of this group. Wherever you meet with the other medical forum, we should talk about these things, because we can help them better with symptom management as well as preparing the family for what is happening. We are the best people who can do that.
Yeah, I think once you are able to make them understand what you can do in terms of pain management and symptom management, I think the other specialty doctors will feel that you are also an integral part of the team. You are not there to take away their patient, but you are there to help them so that they will have their good rapport with the patient, because they are giving a good quality multidisciplinary team kind of care. So at least a few of them will understand the importance of having a palliative care person in their team. That's what I think about it.
Yes, ma'am, but I think it will take time, more
Yeah,
time.
exactly. Yes, it's not like you can go today and talk to your colleagues and be in the emergency department doing palliative care. It will take time. They have to understand basic concepts. You can, whenever you get a whenever you get a tea time together, you can talk about it. And if some forums or meetings are happening, just ask for a few minutes and talk about it. Like people, suppose if Palim India was not talking about all these things, you might not be aware about this scope of palliative care beyond cancer. So it's very important to talk about what you have seen and what you have learned. and it will take time. It's not an easy task.
I think just may I add here, Dr. Sridevi.
Yeah.
I think what we need is a complete image makeover of palliative care.
Yes, exactly.
Palliative care is associated with what they call it as very soft specialty, tender loving care, and it's all about charity, and it's not considered as a serious medical business. In fact, it's a serious medical specialty, and if only we establish that it is by itself a serious medical specialty, it should be available along with other specialty in any conventional hospital. We'll never be able to achieve what we are trying to talk about. Yeah, I think it's very important to have that image makeover.
Yes, exactly. I think that has to come from we all. Like we need to identify that we are also doing a specialty care. Then only we can convince other that. And I had the same impression, Dr. Krishnamar. But when you talk to other doctors, that we can improve the symptoms, we can improve their symptom management. At least some people are happy to try it out. At least some people are happy to collaborate with that. You can find at least a few in your hospital.
Okay, ma'am. Thank you.
And thank you for your queries, because then only we will understand what you are going through, what kind of practice, and what is the challenges that you are facing there. And thank you so much for that query.
So, any more queries? Any more experience you wish to share too? So, if you are not having any doubts, I think we can log it off for today.
I would like to thank Dr. Gayatri for spending time in between your schedule, and that is something we also learned a lot of things from your presentation, and thank you so much for being with us today.
Thank you, ma'am.
So thank you all. Over to Raju, maybe anything for next week.
So we will see next week on next Tuesday, 12th of March, with a topic on gastrointestinal symptoms taken by Dr. Babu Raj. I'm providing a link for today's class feedback. Please do log in and give your feedback. It's very important for us. Thank you all for joining. We will see you next week. Thank you.